Hey there, I'm Dr. Steve Mailer. Welcome to another continuing education webinar. This one is on closing lacerations and bite wounds, but focusing on taking the tension out of wound closure. When we discuss the idea of something being tension-free, it can relate to both creating an incision and the tension lines and how we want to make that incision, but we'll mostly focus on closing incisions and how to make sure we have the least amount of tension on that incision as possible, because tension really is the killer of wound healing when it comes to primary wound healing and incision closure. And so we'll kind of briefly go through the classifications of closure, why tension isn't good for anyone or any wound, and then different options to help address that. So if we look at the classification scheme here for wound closure, they're relatively simple. Obviously, there's a lot of variance within each class, but in general, the wounds that should be closed primarily, what we would call primary closure, are wounds that are less than 4 to 6 hours old. And there was a period of time where that golden period was the only variable that we would assess as to whether or not we should close a wound or leave it open. Obviously, again, not that simple. But we also want to make sure there's no obvious gross contamination, that there's no evidence of a crushing injury. That's mostly because these crushing type injuries, the tissues usually take 2, 4, maybe even 5 days before they finally declare themselves no devitalized tissue, and that there's no tension on the closure itself. So just an example of primary closure, although this is a very severe wound, it was made by a machete, but it's a laceration. It's relatively clean, it's acute, there's no crushing injury, and this is a wound that we can flush out and debride if anything at all needs to be debrided, and then close it primarily. So again, there's variations within this. If this was done the day before, there was a lot of contamination, or it was due to a part of a crushing injury, is not something we would close primarily as that patient presents to the hospital. Delayed primary closure is, in my opinion, the most underutilized form of closure of traumatic wounds. And it's simple. It's a little bit of not knowing the etiology of the wound. Is there any crush that's going to be there? Are the tissues going to look worse 24 hours later? And so we'll debride, we'll lavage, and then instead of closing the wound, we'll bandage that wound and manage it open for just 24 hours, maybe 48 hours, making sure that there is no other tissues or progression of tissue disease damage, devitalization that needs to again be debrided before we go ahead and close the wound. So consider delayed primary closure. We'll find that a lot of pet owners, if we take the time to describe this to them, that they're not going to be so against us doing this type of thing. If we give them an option, hey, you can either pick to have it closed right away, or we can wait a few days to close it, they're always going to pick the most expedient. But for those of you that close a lot of wounds and they come back and they've partially opened up or they don't heal at all, consider delayed primary closure. Of course, there's second intention wound healing, open wound management. We know in certain parts of the body this works really well, and it's the miracle of watching wounds heal. But it does take a long time, and it's a lot of management involved. And we had a previous continuing education webinar on open wound management. We're not going to go into that here. Secondary closure is the idea that we let wounds go through all of the second intention healing options, knowing that the wound is too large or in an area where there's too much tension that it actually won't close completely on its own. And so we wait until second intention healing is done as much as it can, and then we go ahead and do a wound closure. A lot of examples of that. Sometimes, again, there's just not enough skin. There's too much tension for the body to completely close the wound, and we just need to help it out a little bit towards the end of that process. And then we're going to really talk about wounds like this, where significant debridement occurred from a very severe crushing injury of tissue. It took a few days for those tissues to declare themselves, and we wound up with the excision of a massive amount of tissue. And how do we close this with no tension? Because again, tension will prevent that incision from healing, all of the tissue layers. So this is the ventral sternum. You can see the front legs in the top of the picture there. And again, this is the axilla. There's a lot of motion here. There's going to be a lot of tension on the tissues. And so we'll go through this later on in the webinar and how we can get this thing closed and not have to worry about it dehiscing because of tension. So we'll really focus on these tension relieving techniques. They're relatively simple, but they are very effective in minimizing the amount of tension along an incision line. We'll briefly talk about some of the skin flaps, and although the word flap often scares a lot of us, there are some very simple local things that we can do to bring new skin into an area to relieve tension. They don't all have to all be these big axial pattern flaps. So the idea that really no wound should be closed by simple approximation if the tension is going to lead to ischemia and subsequent necrosis. In reality, like, how do we know that's going to happen? But everybody will relate to this. You're closing a wound, and in your head, you know, like, ooh, boy, that is pretty tight. I sure hope that stays together. That's when I think it's important to listen to our gut and listen to our heads and take some precautions and use some of these simple techniques to make sure that that this wound doesn't dehisce because of the amount of tension that we're leaving behind. If we look at tension lines, which are useful to some extent, you can see these like silly diagrams in surgical textbooks, and here are the tension lines and how they run in dogs and where we should make incisions parallel to these and not. And I think that's useful, but no matter what, the most useful thing that I find is getting our hands on that patient prior to either making an incision or getting ready to close it. And where are the tension lines? Where do we have the least amount of tension in the skin? It is really important to make our incisions and or close our wounds parallel to the lines of tension. Now, if we all got to work on zebras and tigers, we wouldn't have to remember all these different tension lines. In general, their stripes show us exactly where their skin tension lines are. Although with some of these new breeds that are coming about in the animal space, we may be able to someday have the tension lines drawn right on all of our patients, and we won't have to remember what those tension lines look like. I always relate tension lines to tug of war because it's a great example of the stresses that occur along the rope line when two opposing forces are pulling in opposite directions. That's really what we want to avoid. We don't want our wound, the tension lines, to be aligned with or perpendicular to the force pulling against this rope on both sides. And so when we look at the idea of that, you know, time and tension, just with a little bit of time, a few days of a lot of tension across that incision line, it will not heal. It can't heal. The tissues, the cells are under way too much stress to pull all of those tissues together. It's not going to happen. So imagine it's tug of war with an incision made on that rope, a partial incision. There's no way a wound will be able to handle and maintain itself through all the processes of healing if we're pulling against it. So imagine that this incision is right in the middle, perpendicular to that rope. You can really visualize that this is a big problem. And in fact, if we apply or close the incision parallel to the lines of tension, you're actually creating a stronger wound. As that wound stretches at its ends, it's actually compressing the tissues along the center of that incision. You're actually creating an opposite effect versus pulling that incision apart. So that's why tension lines are really important. And again, you don't have to memorize the diagrams. We can grab the skin on that patient and move things around and see where the tension lines are in a certain part of the body. We never want our incision to be perpendicular to these lines of tension. So what are some tension relieving techniques? Sometimes we don't have a choice. We have to close the incision, or we make an incision that we're going to wind up closing more perpendicular than parallel, or it's not completely parallel to the lines of tension, or it's an incision in an area where there's just tension regardless of the direction of those tension lines. They're simple techniques, but they're incredibly effective, and they add a little bit of time to anesthesia and surgery, but it really overall shortens the expense and shortens the time, because these incisions that come back and dehisce, it's more surgery, more hospitalization, more money for the pet owner. So just simple undermining we'll go through. We'll talk about walking sutures and variations of those, stent sutures and far, far, near, near, and far, near, near, far suturing techniques. And then we'll talk about some of our relaxing incisions and how we can make incisions elsewhere in the body relatively close to the incision we're trying to close to release some of the tension along that primary incision line. And most of the time, this is all we have to do to close almost every wound in almost every part of the body. There are some examples in which this isn't going to be enough. And again, if we do these things and still have that feeling, this is pretty tight, Then we can move on to talking about some of the local skin flaps. And again, don't be scared away by the term flap. I think you'll be surprised to see what some of these flaps actually are and what they do and how simple they can be. So mobilizing tissue, taking advantage of the fact that dogs and cats have a very unique blood supply and blood distribution to the skin compared to humans, we're very lucky because it's a major cutaneous artery and vein that come out through the muscle and then branch out into the subcutis and skin. And so there's not all these small arteries and veins penetrating through the muscle, feeding the skin, and in which case some of these techniques would be damaging. But we can undermine or creating dead space, which we need to be careful. There are some risks of tension relieving techniques, but we're increasing dead space a little bit all the way around the wound, 360 degrees, and we're just separating panniculus muscle from its underlying tissue plane. So really going between that deep plexus of vessels, the hypodermis, the panniculus muscle, again, that muscle that's attached just underneath the skin, and we're creating that separation. We're increasing the dead space, but by doing so, we allow for this inherent elasticity or potential of the skin. And this is a great way of decreasing or minimizing tension. Very simple. And in this technique, in a lot of cases, is enough. And sometimes it's not. So this is just an example of what we're doing. You're lifting up the skin edge. And again, just going deep to the panniculus muscle, which really it's epidermis, dermis, and a little bit of fat, and then panniculus muscle. It all seems to be one layer anyways in most parts of the body. So you just want to go deep to that. And then again, closing that can make a big difference just by doing some undermining. Again, sometimes undermining isn't enough, and we can undermine, create some dead space in doing so, but then use walking sutures to close some of the dead space, but also, again, take advantage of the elastic properties of the skin. And if you think about it, in some ways, a really good subcutaneous closure is oftentimes all we need to remove the tension on the skin. It's the tension on the skin itself that often leads to partial or complete dehiscence. So after undermining, we can just use a very fine absorbable suture. We don't need anything big. We don't need anything non-absorbable. And we're going to just take some interrupted bites, starting from the dermis down to the center of the wound bed. So you're literally walking the skin towards its midline on both sides. So you can see in this picture here, we're going very far away from the wound edge towards the, we'll say, lateral aspect of the wound. We're going to bite just into the dermis, and then we're going to bite down into that deep fascial layer, but we're moving that second bite towards the midline. And so when we tighten this, it's going to pull the skin towards that center line. And so now most of your tension is along these tacking sutures or walking sutures instead of on the skin itself. And you do that on both sides. And again, a lot of times this combination of undermining and walking sutures is all we need to get a lot of these wounds closed and not have to be worried so much about the tension on the skin itself. Again, sometimes you can accomplish this just with a really good, either interrupted and sometimes continuous subcutaneous closure. This is a massive wound, obviously. It's been being managed open. Luckily, this is a breed that has a lot of extra skin, but both to mitigate dead space and to make sure that our final closure is tension-free. You can see all these little dimples. Those are our walking sutures. And you do have to be careful with walking sutures. You don't want to accidentally cut off blood supply to segments of the skin, or make sure that there's not this direct cutaneous artery and vein that happens to be ligated iatrogenically during this walking suture process. And it is a little time consuming, but again, it's a lot less time consuming getting it done right the first time and letting the body heal versus having to go back a few times because of dehiscence. So I mentioned flaps, and here's an example of a non-scary version of a flap. These bipedicle advancement flaps are really just a fancy characterization or classification for releasing incisions. These are more likely done on the limbs, but in the perineal region they can be useful too, where you make a completely separate incision close to and parallel with your incision you're trying to close. And either you close now your primary incision and you've got partial closure of the new incision you've made that's going to heal by second intention, or you can do these multiple punctate or mesh incisions. And by making a bunch of small holes that are about 1 centimeter in length, parallel to your primary incision, spaced around 1 centimeter apart, you can very easily close your primary incision, and then these very small mesh incisions heal by second intention, and they do so very quickly. And there's an example again. This is a mass removal, not a trauma case, but really very little skin to work with here. And this is probably where most of us get that feeling of like, oh boy, this is tight. And not only we're going to have dehiscence, but we'll probably get some venous obstruction, some lymphatic obstruction, which is going to be very uncomfortable. So instead of worrying about a big flap being done or a free skin graft, this is a bipedicle advancement flap in a lot of ways. These small punctate incisions, we now have a tension-free wound that we can close. And again, there's been undermining that's been done as well. And then these little holes allow for two things. One, drainage, which is great. And two, they're going to heal up very quickly. And you can see already, just even at the surgical point, this seeping of what would be normally seroma, which would put even more tension on that wound. So of course we have to bandage this. We have to keep these little holes protected and allow them to go through their process. But even in a couple of days, we start to get what looks like almost complete second intention healing. And so we don't need to keep these patients in bandages very long. Another more advanced version of a flap, but those of you that are listening that have done Z-plasties or something similar know that in certain areas of the skin in the body, this is a very useful form of reconstruction, tension-free. And the nice thing about this is, although we're creating another set of incisions to get a primary incision closed, we're also closing this second or Z-plasty incision up completely at the time of surgery. There aren't a lot of parts of the body where I find this to actually be useful. Most of the areas that it would be fun to do, we actually don't need to do it because there's a lot of free skin that we can undermine and mobilize. But there are some great areas of the body, again, limbs, axilla, inguinal area, even the medial lateral aspects of the stifle or the elbow, where this is very useful. The basic principles here is that the kind of that x-axis or that central arm of the Z has to be perpendicular to that axis of the wound that is also the short axis. So you want to have that perpendicular to the long axis of the actual wound itself. And then depending on the degrees that you make the arms of the Z coming off that central axis, you'll either gain more skin, therefore less tension, or less skin and keep a little bit more tension. So in general, you know, these roughly 30-degree, 45, 60-degree angles, again, that bigger those angles, the more gain you get in new skin coming into your wound, which means you get less tension. I would say starting with and sticking with a 45-degree angle somewhere around there, and I do not get a protractor out anymore. I used to. Again, we're talking about relative degrees here. 45 is more than enough. If you need more than 50% gain of skin, I probably am going to start looking at other methods to decrease tension on the wound. So this is a cadaver wound, but it's a great place to demonstrate this. You've got this wound here that is about 3 centimeters wide. So again, you're measuring your perpendicular axis, the one that's perpendicular to the long axis of the wound. It's 3 centimeters. That's about the distance that I'm going to start my central limb of my Z-plasty from the edge of the wound. So you can see that 3 centimeter mark. That central limb is also going to be roughly about 3 centimeters. So that width of the wound, that's the distance I make the Z-plasty away from the wound, and then the central limb length is roughly about that same length as well. And again, you can see that central arm is going to be made perpendicular to the long axis of the wound we're trying to close. And then again, this roughly 45-degree angle for the arms of the Z. And then once I've drawn that out, you don't have to do the sterile purple marker thing. I love using it. It helps me a lot in planning these and making sure my cuts are where I want them to be. You're going to incise the arms of the Z. And these black and red lines are on here because it's a good visualization of, as you close your primary wound, those black stripes and the red stripes of the Z are going to change their direction and location. And that's where you're gaining that new skin from. And that'll make more sense. So we've made that central incision, and we've made the incision of the arms of the Z. The black and red stripes are still where they're supposed to be. And then as we undermine the tissue between the Z-plasty and our wound edge, you'll see already those red and black stripes are starting to change their orientation, even in the cadaver skin. And you're going to go from what started as this to what becomes this. So it's almost like it becomes a backward Z, and that's a successful Z-plasty. Again, starts here, and they switch spots and switch direction. And that's what you wind up with here. As you close your central wound, you're having this displacement of your Z. Now your central arm of your Z is more parallel to the length of your incision, and that's really what we're trying to achieve. And this is a great way of decreasing tension on your primary wound. Again, just to start, we started like this and we ended like that. So here's in a clinical case, this is the medial aspect of the stifle, a traumatic wound, a little bit of management done here, open wound management. This is really a good example of delayed primary closure. And although you can see the Z, which that central arm was perpendicular to the long axis of the wound itself, in a live animal, as soon as you make your Z-plasty cuts, because of the inherent tension and contraction of skin in a live patient, it already moves on its own. You don't have to do a lot more than what this is going to be. And you can see when we close this, that central arm becomes a lot more parallel to that long axis of the wound. And so this is how it started. This is how it's going to wind up. And you gained a lot of extra skin and have decreased the tension on your primary wound closure. So Z-plasty is very helpful, a lot of fun to do. Again, I think if you have to make your angles greater than 45 degrees roughly, there may be a better option. It doesn't mean that you can't make them larger. A lot of people do. I just feel like I'm pushing the limits there in a lot of cases. So we'll move on. You know, if these bipedicle advancement flaps and Z-plasties and U-plasties and H-plasties, there's all these different plasties. They're just the same variation. Or they accomplish the same thing, just different variations of them. That's where we can start looking at local flaps. And again, if I'm doing a local flap, there's a lot of tension on that primary wound, or it's a large wound, or it's in an area where there's just not enough skin heading in the right direction to feel comfortable closing it. Again, we're taking advantage of the fact that dogs and cats have this incredible blood supply, very convenient for skin and reconstruction techniques. And really what you're doing is taking a partially detached segment of skin and subcutaneous, so again, underneath that panniculus muscle, and you're just moving that skin into an area that has a lot of tension. There's less mobile skin, less elastic skin. So this is always going to be adjacent to, and an edge of your flap is always going to include your primary wound. So you're not having to worry about finding a direct cutaneous artery and vein. It's not an axial pattern flap. It's literally, again, taking advantage of the fact that dog and cat blood supplied to the skin comes from these large direct cutaneous arteries and veins, and then are segmentally splitting off into the panniculus layer of the skin itself. And we can go through and classify different types of local skin flaps, but we're going to just focus on kind of the basic, simple ones, the ones that I find most useful in practice, and not spend as much time focusing on what each of them means. And it's more important, I think, to do them well and get a tension-free closure. So if you think about the single pedicle advancement flaps, the things that I would keep in mind is that they're really simple techniques. They really are. I know the word flap is scary, but they're simple. You're not creating a secondary skin defect like the bipedicle advancement flaps, and sometimes you can't close those second defects. In this case, you can, but they're really only limited by the availability of adjacent loose elastic skin. So there are areas where this is not going to work well, but the flank, the axilla, the inguinal area, the neck, on the head, these are areas where we've got, at least we think we'll have adjacent loose elastic skin to move some skin around. I think the other thing, other than, you know, we got to keep the flap length to a minimum, and I'll show an example of that. The nice thing about axial pattern flaps is because we know the blood supply really well to those direct cutaneous arteries and veins, we can make the flap length a lot longer. We get more out of that flap. Here, we just want to be careful, because as those vessels may be thinning out, or there are different parts of the skin are being fed by different cutaneous arteries and veins, you know, we don't want to make this too long, otherwise it will necrose. A great example of this single pedicle advancement, and you'll see how simple this is. This is just a cancer case, but this dog has a low-grade sarcoma on top of its head. Now I can remove this mass and close it primarily with little tension, but this dog's ears will be on top of its head. It'll look more like a unicorn. And we always also risk pulling the upper eyelids back too far, and then we could get some exposure keratitis. Here's this big wound that's going to be on this dog's head. We're going to try to get this off with margins, but we have all this wonderful elastic skin on the neck. And so how can we take that skin and move it forward so that we're not relying on the skin that's left connecting the pinna of the ears and the skin that is adjacent to this involving the upper eyelids. And so all we've done here, we have our more circular incision or defect we're going to have, and then the red arrows, the red dotted arrows, those are incisions that we're making parallel to each other along the dorsal skin of the neck. We'll undermine that skin, and we're just going to move it forward. So you can see both of those incisions are adjacent to and connecting with that primary hole or wound that we've left, and we're taking that single pedicle, meaning there's one blood supply that's coming into it versus the bipedicle releasing incisions we mentioned to get this closed. So we're pulling all of that forward. This way, the ears get to stay where they are, and there's plenty of skin still elastic connected to the upper eyelids. And this is not the same dog, but a similar example. We're able to keep the pinna where they are and not affect the eyelids at all. Another great example of this, where I also find it useful, are these very caudal, ventral, perineal, either wounds, bite wounds that abscessed, or even tumor removals, where we can take advantage of this mobile elastic skin in the ventral caudal abdomen and inguinal regions, where we got this large defect here. We've already made our parallel bipedicle incisions. It's going to create this single pedicle advancement flap, undermine all of this, and this is what we want to close. There we made our incisions. You undermine that flap, and again, we have this nice tension-free closure based upon a single pedicle advancement flap. That's what we did in this case that I showed earlier on. Massive wound. How are we going to keep this closed and with no tension? We've really lost some of our options for our axial pattern flaps. There's too big of a wound, and we're involving too much of the normal blood supply. But if you think about that single pedicle advancement flap that we did on the head, we can do that on both sides of this wound. So that axillary skin is probably some of the best elastic skin that we have in the body to work with. And so we can make the same thing happen here. We can look at our options and realize that primary closure with just undermining and walking sutures is not going to be enough here. Second intention healing, not going to happen, but local flaps are a great place to go. So that's what we've done here. We've got that big open wound. We've made two parallel incisions moving away from that central wound, but including the central wound as the edge, going into the armpit and the left thoracic flank on both sides. And now we're moving two individual single pedicle grafts towards each other. And we wind up with really a tension-free closure in an area that's very difficult normally to try to get closed primarily. So that's a little bit more of an advanced single pedicle advancement flap, but only because we've done it on both sides of the wound, and very, very effective form of closure. So if we're looking at the other bipedicle advancement flaps, we're always trying to adjust it that the flap width is equal to the defect width, which we really went over when we already discussed like the Z-plasty, for instance. We want to make sure that our flap length is no larger than the length of the defect. And again, we got to make sure that the length of that flap, that we're not making it too long. We have to undermine carefully. We have to be under the panniculus. We don't want to accidentally damage a primary cutaneous artery and vein, but we can see those as we're doing our undermining, and then again, advancing the flap. So we already mentioned these mesh incisions and bipedicle advancement flaps. This is again just kind of a repeat of that, because it's probably the most common form of flap that I use and that I see a lot of veterinarians use. So this is a very simplified version of this, and just what I was saying is that that distance X from where we're making our incision, that's going to be parallel to our wound, is the same distance of the width of the wound. So X is the width of the wound, X is the distance that we're going to make our releasing incision from the edge of the wound. And then roughly the length of that releasing incision should be 4 times X. So it's 4 times the width of the original wound, and it's 4 times the distance that we've made our releasing incision from the wound. Again, what that does is it gets us access to more elastic skin. We can get the wound closed primarily, but now we've got this other wound that we've created that we can either partially close. Oftentimes you can't close it, especially if we're like on a limb. Now, where would this be beneficial? If it's in an area of high motion, for instance, the elbow joint or the carpus, I'd much rather have this open wound that I've created, somewhere where there's not a lot of motion. So next to an incision or a wound that's over the carpus or over the elbow or over the knee, and have my primary skin closure over one of those areas. Where I use this more frequently is in the perineal region. It's a great example. This big open wound here from a cat bite abscess. I don't want this cat to continually being defecating on this area and contaminating it. So I can make a releasing incision further away, and now I have all this elastic skin that I can close, and so that my open wound isn't being contaminated with feces. We're undermining from our new incision, our releasing incision. We're going to be able to now have a lot of extra skin here to close, and if that other wound's got to heal by second intention, or we can partially close it, that's fine. At least we're further away now from the anus, and that's it. Just a couple weeks later, and it's almost done with its second intention healing. Sort of a happy kitty. That's a long time to wear a knee collar for a cat. Transposition flaps, a little bit more complicated, but not difficult. And the reason why I even bring them up is because they are by far the most versatile of our local flaps. This is still going to be utilizing loose elastic skin adjacent to the wound. We're still going to be including the wound edge as part of our flap or our incisions that we make. But why they're nice is that they're, in general, it's a rectangular flap that we rotate within 90 degrees of our actual wound. So it allows a lot of freedom and a lot of areas we can bring more skin in and get large defects closed. So that's why I like this one. And these types of flaps, because we're mobilizing large rectangular limbs of the flaps, oftentimes we're just less likely to distort or impair function like some of our other flaps may cause. And again, this is all about feeling the elasticity of the skin, where it wants to be, where the tension lines are running. We want to be parallel to that if possible. And this is just an example. Let's say we had a large defect here on that caudal lateral flank, and we can see where our tension lines are running from pinching the skin and where they're not. This would be a great area to make a rectangular flap and flap that or rotate that in to keep our defect closed. Again, a cadaver, but just as an example, this is a square wound, which we don't often see square wounds, but it's just an example. We measure the length of the wound, in this case, roughly 4 to 5 centimeters, and then we're going to make a mark or a line that is adjacent to the wound, heading into where we want our flap to be harvested from. So the free end of the flap is going to be that wound edge. The base of the flap is going to be back where we're marking the skin at that 4 to 5 centimeter mark away from the primary wound. You don't have to do this, but I find it very useful. How long can we make the flap? What's kind of that maximum length, and how long should it be? I then measure the distance between that X or dot that I've made and the far corner of the actual wound bed, the furthest point from that dot to the wound. And that measurement there is the length that I'm going to try to keep my flap at. Number one, I want it to go that far with little tension. And two, we probably don't want to make it much longer than that. So that's what the white line is. The white line is supposed to represent the distance from that point to the furthest point of the wound, and then the length of that coming perpendicular to the first black line. So you have the width of the wounds measured. That's how far away we're going to make that first black line. That's where we're going to draw a little dot or an X. And then that measurement, the diagonal white line, is just the measurement. We're not making an incision there. The white line that is perpendicular to the black line, that's where we're making our incision. And so you can see here the base of our flap, the edge of our flap, and what we're doing is keeping the width of the flap the same as the width that we measured from the wound edge to where that big black dot is that we made on the skin. So you're going to incise along that purple line, and that's the only place we're going to incise. We'll undermine that, as is done here. Again, we're deep to the panniculus layer, and then you can flap that or rotate that in to close your primary wound. And because we've made it in an area that's adjacent with a lot of loose elastic skin, we won't have any issue closing that harvesting site, the donor site where we took that skin from. This is a very effective technique to use in a lot of different places in the body. And here's the actual example of it in a live patient. We've got a large wound to close. We went ahead and made our measurements. We've undermined the flap. We're going to rotate that flap in and then be able to easily close all of it because we've harvested it from an area of loose elastic skin. One of my favorite places to use something similar to this are those chronic open wounds on elbows, whether they're hygromas that got infected, whether there was a tumor there you removed, or it's a trauma case. You know, trying to close, and you can see this one had been closed a few times. You're going to keep an incision over the olecranon, like good luck getting that thing to heal. What we need to do is bring in new skin to this area, a different kind of skin, a thicker skin, a more elastic skin. And again, we're in the axilla. This is one of my favorite places to harvest nice, loose, elastic skin to bring into a wound. So we freshen the edges up and get rid of all that kind of contracted, old, exposed tissue. And this is a transposition flap, but really the principles are no different than we just discussed about the other type of flap. We're going to use roughly a rectangular piece of skin, and we're going to make our measurements so that we have our base and we have our flap length. We're going to make our incision, we're going to undermine, and we're going to rotate that into our wound, which is going to create a post-operative effect where our incision isn't sitting right over on the top of the olecranon, and we're bringing in this nice thicker axillary skin that's a lot more mobile. And this is it's like a nice elbow pad that we're suturing in place for this patient. And again, they're going to get a hygroma there again, most likely, but at least it's a healed callus. Rotational flaps, again, just another variation. These are great for more circular and or triangular. The places where I really use these are on the flexor surface of the limbs. So the flexor side of the elbow, the flexor side of the stifle, even sometimes on the flexion side of the carpus or tarsus. But that's where I find these most useful. And if you just take a look at what's happening here, and if you just take a look at what we're doing here, you can see this big, roughly circular type wound that's on the flexor surface of the elbow. Again, you can imagine trying to close this primarily, not going to stay closed, lots of tension, even if we immobilize the limb, not a lot of skin there. Now, there's other flaps that you could do here. You could do an advancement flap, you could do a bipedical flap, but this is where a rotational flap is just a different variety of that. And so I'm making an arc in the skin here, this loose axillary skin that we still have access to. And I'm making this one incision in this case and rotating it in. And just to show you what that's going to look like, we've extended that incision now. And this white star that shows up in both images is going to go to the white star that you're seeing on the far end of that wound defect. The green star that shows up on both images is going to go to the green star that you see on the far end of the wound. And so we're undermining that piece of skin deep to the panniculus and rotating it into place. Very useful flap, I think, again, on the flexor surface. You can also use these on the head. Again, kind of like we talked about the single pedicle advancement flap. Sometimes this can be used on the head as well. We're not going to dive in and spend a lot of time on the axial pattern flaps. Just the difference here is that we're truly identifying anatomically where these large direct cutaneous arteries and veins are, knowing that we can harvest a much longer, wider flap and becomes much more versatile. So there's a lot of different axial pattern flaps based upon known arteries and veins that are feeding large areas of skin. Again, we're not going to go through all of them, but they have their utility. Large open wounds, chronically managed, that are taking up large areas of skin, in this case, the distal humerus and part of the ulna and elbow. And this is the thoracodorsal axial pattern flap. This artery and vein come out just caudal to the scapula shoulder joint area, and those large arteries and veins and their branches run caudally over a large mapped out area of skin. So this is where we can harvest a really nice long flap. There's the scapula there. big flap, very easy to actually close this large wound that we've created, and you can flap that down to an area that has a lot less skin. We're just not going to be able to mobilize enough skin to get that large area closed. Again, we're not going to go through all of them. This is the best known, probably the most robust axial pattern flap. It's the most consistent of all of the arteries and veins that we can find as direct cutaneous arteries and veins. And it's this caudal superficial epigastric flap. I mean, we can put this flap just about everywhere. Back legs, front legs, flank of the other side. You can harvest both at the same time. You can really close a lot of space with these types of flaps. I will tell you that although axial pattern flaps are cool and I love having them planned out, it's rare that I have a wound that I think, yep, we're going to need an axial pattern flap, and I shave the fur for it, that I actually wind up using them. The techniques that we talked about prior to axial pattern flaps, in most cases, will close wounds without much tension. And again, it's fun to do axial pattern flaps. It's a lot of reconstruction, but it's truly rare that I need to use them. This is just another example, this deep circumflex iliac flap that has both dorsal and ventral branches. So sometimes we need it, and it's great to know that we can use them, but it's not common. Free skin grafts I do infrequently for a reason. You're completely removing the arterial and venous drainage from a segment of skin, moving it somewhere else on the body, and hoping that the physiologic processes of putting brand new skin somewhere else without an artery and vein can happen, and that skin can take. The idea is great. It's very rewarding to do these, but we're literally taking skin from somewhere else and attaching it to another place where there's no skin. And you have to be careful. Early in my career, when I would tell a particular pet owner, this is in my residency, this dog's name is Baloo, I'll never forget him, it was a Weimaraner hit by a car, had a bunch of fractures, metacarpal, distal radius ulna fractures, and we had an external ring fixator until it was the bones were healed. And I told the pet owners, once the bones are healed, we're going to go ahead and do a free skin graft, and they were very grateful. And when they cashed out, they were unhappy because they owed money for the free skin graft. So now I'm very clear in defining what a free skin graft is. It's taking skin from somewhere else. These are the phases that this new skin has to go through, this plasmatic imbibition. Basically, the donor area has to secrete all these plasma-based nutrients, which it's going to do, and then it has to be pulled into the graft, and then eventually arteries and veins, venules and arterioles will meet up with each other from both the graft and the donor site. They connect, and you have healthy skin now attached, being a part of that part of the body. Hard to do in a dog or a cat, because any type of movement, motion, even if we're in a splint and bandage, can tear, as you can imagine, these teeny tiny little microscopic vessels that are trying to anastomose themselves. Doesn't mean we shouldn't do these, doesn't mean you can have partial graft take and have a much smaller wound, but most of the time we can get wounds to heal with the other techniques that we've talked about. This is more just the, if we really need to, we can. And these are just very difficult areas to move skin to without doing a free graft. We're using oftentimes lateral flank skin because it's so elastic and it's easy to close those areas. And that's all that we're doing here. We're going to take this skin and we're going to transect the skin that includes the subcutaneous tissues, just so that we can close that wound bed, the donor bed, very easily, and which always seems to close up great. But the problem is, if we want to enhance that graft the best we can, give it the best chance of absorbing those nutrients from the donor site, we've got to strip all of the underside of that graft skin from its subcutaneous tissue. We got to remove all of it. The subcutaneous tissues, the fat, is going to absolutely interfere with this graft taking. The other thing we don't want is any kind of seroma forming, because that'll also prevent the graft and the donor area from connecting themselves. They'll be kept too far apart, and those little vessels aren't going to be able to grow together in anastomose. So I also like to make little teeny incisions, these little meshes. That way, anything that would normally lead to a seroma, that fluid's going to leak out. And you can see we've stripped the entire dermal side of this graft from all of its fat, and then we're just going to suture it in place. Again, we've got to expect and hope that we can immobilize this enough, that we've cleaned the undersurface enough, that all of the wound bed fluid and nutrients are going to be taken up into the skin, and that eventually the small microscopic vessels are going to anastomose and it'll all become one piece of skin again. And so it's possible, it works in some cases, but it's always my last effort. If amputation is an option, it's absolutely worth trying a free skin graft. But it's a lot of surgery, and you're truly creating another major surgical wound that you're closing to get this new skin down here. So it's something to consider if people have questions about cases in general with skin and reconstruction, or you're considering a free skin graft. You can always get a hold of me, and we can talk through some of it if it's something you're interested in doing. So just remember, tension is going to equal dehiscence, partial, complete. Those of us that have been practicing for a while, we know that we have seen this. And I love to try to blame these things internally on pet owners and e-collars and bandages and all of that. But in reality, we all know that feeling that this is going to be a little bit too tight. And then it comes back with partial dehiscence, and we're like, yeah, I knew it. And it's, why not take the extra time and mobilize tissues, undermine, tension relieving sutures, relaxing incisions. And I'm telling you, most of the time, that's going to be enough to get that wound closed tension free or with minimal tension. But if these relaxing incisions aren't enough, those bipedicle advancement flaps aren't enough, consider some of the local flaps. And worst case scenario, you may be looking at axial pattern flaps. But again, of all the cases that I've recalled, like, oh, I'm going to have to do an axial pattern flap, and I shave all the fur and I'm ready to do it. It's rare that I have to actually do an axial pattern flap, let alone a free graft. Ultimately, it's always eliminate our dead space the best that we can and make sure we protect our repair, whether that's sterile bandages, whether that's splints for areas that are under a lot of tension. But closing wounds with minimal tension is possible, and it often doesn't take much work, and the techniques are often very simple, just to get that little extra reassurance that tension isn't going to be the reason why your wound falls apart. So if you do have any questions, feel free to reach out anytime, and always happy to chat about surgical cases and wounds. And I hope you enjoy the continuing education webinar, and we'll see everybody soon. Take care.